Hi, everybody, and welcome to our very first lecture for the Value Drug CE trip. In this lecture, we're going to be talking about clinical opportunities in community pharmacy to improve patient outcomes. Now, just with every talk, I just want to disclose that anything that I'm discussing, I have no financial conflict of interest in relation to this presentation, outside that I am a practicing clinical pharmacist, but most importantly, I'm a practiced independent community pharmacist. And like all of us, we're always trying to find new ways that we can improve the services that we offer to our customers and patients to help their everyday lives. So today in this lecture, we're going to be talking about the following learning objectives. And you can see that I posted on our teaching site an overview of all those learning objectives, and so you can read them. But I will go through, as this talk and every talk, I will highlight what section we're going to be going into. And so to begin this talk, we're going to start looking at what value-based healthcare is and how we as a pharmacist can play a role in this. Now, we all know that in our lifetime, we have seen many changes in the healthcare system. We have seen things such as some of us saw the creation of Medicare and Medicaid. All of us experience that every day. We've seen from the implementation of the managed care system to what we know as the practicing of PBMs in the late 80s, 90s, more where they became more dominant, and especially here in the aughts. We've seen the adoption of Medicare D. We've seen the Affordable Care Act. And as we know, that follow the politics of our country, it's still the great unknown of what our healthcare system may look like in the next couple years and the next 10 years. But the one thing that, regardless of what changes that has occurred, is we've gone more from a fee-to-service healthcare system to a value-driven healthcare system. And that is basically mean that we're trying to find in our healthcare system that we're paying for good quality services, that these good quality services are providing value to the patients, to the healthcare system, and reducing healthcare dollars, but maintaining quality and improving that. The biggest struggle, like we always deal with in pharmacy and the medical profession, is that how do we agree of how do we define what is value and what measures do we look at? And the main reason why this has evolved is that, no longer do providers want to pay for just people showing up and doing their job. They want to make sure that the care that's being delivered, all right, is providing the best and the most effective to lower healthcare costs across our healthcare system. And this is often being implemented now, and we see this in our own pharmacies with Medicare star ratings, with pay for performance, is that there are incentive ways to allow us to do this. And if you, as all of you are involved in an independent pharmacy business, you know that we're always driven by incentives, and sometimes the incentives are to our advantage, whether it's in purchasing, whether it's belonging to different, to our wholesaler, to different organizations. But what's happening in this value-based healthcare system are these incentives are basically being tied to reimbursement. And this is specifically being seen across all realms of the healthcare system. It also encourages that the best way that studies have shown that these incentives to be met is there has to be an integration of these clinical services with the various entities that touch the patient that we're taking care of. And probably where we struggle right now here in 2017 is we have the technology, we have the pipes built of how to connect all these systems. It's just trying to get those systems to be able to talk together. We're going to talk in this lecture opportunities that we can explore. But then the next lecture, we're going to talk about how we can do this possibly through collaborative practice agreements. We all know, as a pharmacist currently working in the community pharmacy workforce, that when we come out of school, and for those new hires that you've hired recently that are recent grads from the 6-year program, they're loaded with knowledge. In the 6-year curriculum and in prior curriculums, we throw disease state management, pharmacology, kinetics, dynamics, pseudocics, and pharmacotherapy. But the way our workflow system is and the way we've been incentivized over the past and the way we've been successful in businesses to provide to our patients is that the way our stream of revenue to stay in business is being tied to a product. But as we all know, that in the years you've been a pharmacist, in the years you've worked in pharmacy, that the product is the means of our pay. However, the services that we offer are invaluable, whether they're education services, whether they're consulting with physicians. We have developed these communication skills. And so it is the ripe time for we as pharmacists to think about this. Because if you look at the history of pharmacy, and this slide here I have here is a picture of my family's pharmacy, Patton Pharmacy, and this is the original store, which we're no longer at. But just take a look at this is a picture from the 1970s. You got the Marlboro cigarette ad there in the front window. You got the big ad to attract senior citizen discount because we didn't have PACE in the 70s and we didn't have Medicare D, and we were also the big stop for health and beauty aids. But during the time period from the 70s and beyond, what have we seen? We've seen the development of pharmacy going more into the clinical realm, especially in the education system with the clinical doctorate programs. We've seen the way Medicare is reimbursing hospitals, physicians, and we see that with our own reimbursements with pay-for-performance contracts. We've seen competition grow among us through the chain industry, through the mail order industry. And although it's been tough, we're still standing. And we've been able to do this by taking care of our patients. And although we still have to fight for this every day, we're still here. And where does that future of pharmacy lie? It may lie in the development of education and wellness programs. See picture below, this is a snapshot from our diabetes education conference room where we actually perform diabetes education. This is one of our dietitians talking to the group. But the key thing, though, is we offer these services. We need to look as, business people of how can we incorporate these into our pharmacies. How can we maybe possibly incorporate them into our everyday workflow for our pharmacists and technicians? And the final thing is, how can this become an incentive revenue stream that will allow us in the future to provide these services to our patients and customers? Because we know we're all been faced with challenges in the past year and the years past. All right, our net income, our bottom line is very difficult. Our gross margin, we struggle with our contracts with the PBMs, and looking at that, our gross margin is what pays our bills. And we are tied that close to 90% of our revenue falls on filling a prescription. And we're constantly battling with payers what it costs to dispense that. And I'm going to talk about other services. And one of the services that has been allow us to grow is immunization, but we constantly have threats that people want to cut that. And so one of the things to stress that as you are trying to make this involvement, we still have to not give up the fight to preserve reimbursement. Now, why should we enter this realm of other types of clinical services? Well, if you think about, as I talked about earlier in this talk, the challenges that we have is that, you know, we are just being paid for product. However, we see the patient more than anybody else in the healthcare system. And if you look at the expenditure of pharmacy, is that it is a small portion of that pie. And the most costly things to our healthcare system are hospitalizations, ER visits, and readmissions. And you think about the chronic diseases that our country faces every day. Cardiovascular disease, diabetes are probably the top two that stand upon that. And think about this. When we think about cardiovascular diseases and we think about diabetes, unfortunately, have we found any cures for these diseases? No. But how have we been able to manage these diseases, prevent the progression of these diseases, to prevent them possibly from ever occurring if somebody's pre-diabetic or in a pre-hypertensive state? Well, the medications have been able to do that, along with education of disease states, along with other things to try, such as dietary products, vitamins, and who plays a big key role in that? And that's the pharmacy. Because if the patient doesn't take the drugs appropriately, or those drugs interact that they can't work appropriately, then the cost to the rest of that pie continues to go up. And so we play a key vital role in this. And as I said, the prescription drugs account for only about 10 to 15% of the healthcare spending, all right? But we, as pharmacists, could significantly reduce this. Now, we've had different people try to incentivize us, mainly our PBM payers, by trickling down these pay-per-performance. But, although these contracts have been come in there, they've been seen more as a penalty than as an additive incentive payment. And so we need to start thinking about this paradigm shift. This pay-for-performance type of, healthcare is not going away. But where do we lie in this connectivity of healthcare? We need to start thinking about how can we start developing services that either now or in the future might be able to be paid by other streams of revenue on the medical side of healthcare, not on the PBM side. If we think about the PBM side, and we know that we don't always have a love for that side, all right, is that side ultimate job is to reduce drug cost. That side is not incentivized to really, outside of the star ratings, to help lower the cost of other realms of healthcare. And so, but we as pharmacists have that ability. We connect to this patient every day. And if you think about it, we are there at the pharmacy level, but we connect with the specialist, the primary care patient, the primary care physician. We may be checking labs. We may be also relaying to the hospital, an updated med list to the patient, or dealing with somebody just recently discharged from the hospital. So every day we are touching different realms. We as the pharmacy, if you look at this picture representation, we are tied to all these different healthcare entities. And what has been evolving, and even if the Affordable Care Act is repealed and replaced, as we hear in the news, there has to be changes to our healthcare system that allow us as pharmacists and the experts in drug therapy to be tied to these entities and possibly in the future to be reimbursed for the services that we provide besides dispensing a product. This is just a snapshot of all the different incentive programs that are out there, especially through the CMS system. And if you take a look, Down here is those Medicare star ratings. But if you take a look up in the hospital setting where some pharmacists have entered into transitions of care, there is the hospital readmission reduction program, which affects reimbursement for hospitals. We also see physicians possibly being incentivized for improving their quality measure markers and maybe getting paid more, or the reimbursements not being cut by participating in a pay for performance contract. Because the end of the day, pharmacy, through our ability to make our patients more adherent, to educate our patients, to identify possible problems with their drug therapy, is a couple things. The more we talk to our patients, encourage our patients, the more we're going to hopefully increase, increase that they're taking their medications, and so you see drug medication costs go up. You may see also, because of our incentives to work with their physician, that they are attending their physician visits more often. And those are costs that do go up. However, the costs of those far outweigh the reduction in cost of inpatient admissions, specifically costly diseases such as diabetes, congestive heart failure, any of our other cardiovascular diseases, preventable admissions, preventable readmissions, making sure the patient gets their drugs after discharge, making sure the patient understands what meds they should be on, what meds they should continue, what meds they should discontinue, and also making sure that they're aware of the risks that they don't end up in the ER. For example, a diabetic patient understanding how to treat hypoglycemia that may decrease their chance that they don't have to go to the ER. How educating an asthmatic patient on how to use a rescue inhaler and how to use a peak flow meter so they don't have to have an ER admission. So we as a pharmacy, we as pharmacy, as part of this healthcare system, have a great impact every day, and it's time that we start spreading that in our voice. And that's one thing our pharmacy organizations have begun to do and have seeked out for grants to show the value that we bring. But as I said earlier, the big picture is, as we're trying to evolve to this next state, is we need to preserve product reimbursement. We need to be fighting for in-network status with PBMs. We need to be fighting for the unfair payment system that we see now of DIR fees. We need to start looking at, well, how do we get into the payment system of what we do from a medical benefit side? And one of those possible ways is that I'm going to show you through MTM and through all, MTM is the key pin, but we are starting to see what's developed what are called these enhanced pharmacy service networks. And what these enhanced pharmacy service networks are, they're making a standardization. I once had a gentleman from one of the big health plans here in Pittsburgh say to me, and this was about 15, 17 years ago, that the problem with why we can't reimburse pharmacies for their clinical services is, how do I know that what that person's doing at that independent pharmacy or what that person's doing at that chain pharmacy is the same thing? I know what they do from a dispensing side. I don't know what they do from a clinical side. Well, with the development of MTM, that kind of has gone away. And what these high-performing networks have done is they have tried to standardize, mainly based on MTM principles, of what pharmacy does. And so that argument is that I don't know that they're doing the same thing kind of doesn't hold water. And this has a big opportunity. The other thing is we need to create a care team dependency. We are not a silo where our pharmacy sits on the corner somewhere and the hospital's over there and the doctor's office is over there. We may not always get along. We may have differences of opinion. But our ultimate goal in the community that we live is that we're taking care of that patient. And that patient is our patient. It's our patient as a team. And so if you haven't done this, and I'm sure lots of you have, is that you need to start, networking with these other different entities, attending maybe some of their local organizational functions, letting them know what services you offer, and start developing those relationships that will allow us to not be so dependent on the PBM side and may be able. And then the other thing is you need to also share this with the team members that work with you, from your technicians to the front end clerk. Show them this paradigm shift that you're trying to do, that we are a healthcare entity that is here to help improve the patient outcomes of the patients we serve here at this community pharmacy. And so this is a big challenge. And so what I ask you to today, as you listen to this lecture and as you sit in the live lecture assessment questions, is begin to reflect of what simple service could I go back and start in my pharmacy that I might be able to? What physicians in the area, what hospitals in the area maybe I need to visit to see how can my pharmacy work together with them? Because as long as you're providing health care in the next 10 years that provides value, your pharmacy should be fine. Because we've always done this in the past, and what now we need to do is start organizing what we've done in our excellent educational services and our excellent convenience of how we've helped improve patients' adherence. And all these things matter in helping prevent overall healthcare costs. So that's value-based healthcare. Let's now take a look at how does MTM principles and these skills are the cornerstones of improving patient outcome. One thing that pharmacy law has allowed us to do, and I know some of you are not from Pennsylvania, so I apologize, I don't know all the laws on the state level, but there are some laws that we do know that in every state it is unlawful for a person to practice pharmacy without being a pharmacist. And we need to hold that true, that we are still in charge of the product. I share that with my students every day. Until we can get that 90% revenue to show that we are doing more than just selling product, and our revenue is coming in from other streams, then we can maybe not have to worry. But the practice of pharmacy, we are in charge of that. But if you read your pharmacy acts wherever you're from, the practice of pharmacy also talks about we need to take care of the patients and the disease states they're involved in. Medicare D, it's in set development and its implementation over 11 years ago. Everybody remember January of 2006? It was a fun month, wasn't it? But what else came out of that law? What else came out of that law was the development of MTM services. And those MTM services are what are allowing us to standardize. Well, we've seen in our state of Pennsylvania, we've seen immunization law, which is pretty much standard almost in all 50 states. We've also seen collaborative management of drug therapy. And we're going to talk about that in Lecture 2. And as we push on the national level, we push for pharmacist provider status. And we'll talk just briefly about what all does that mean. But pharmacist provider status is not asking us to be providers so we can prescribe. What provider status is allowing us to do is that we are recognized under Medicare as a healthcare profession, and we can bill for the services that we do involving drug therapy management. All right. Think every time when you talk to a patient, helping them, select a Medicare D plan, or helping them afford a medication, or helping them develop a system that they can remember take their medications. All those things should be billable services. And we'll talk about that in Lecture 2 of how that is possible. So, Everybody probably has attended some type of MTM lecture, so I'm not going over the last 10 years. I'm not going to belabor all the components, but I want you to think about what are those components, okay? So medication therapy managed services are a patient-centered assessment, and you're looking at the whole patient of their medication regimen in relationship to their disease states. And so this is why this goes way beyond counseling of a drug. Think about counseling of a drug. It's just the first time you're telling a patient of this is how you take the medication. In MTM, our goals are to make sure the patient is taking these medications and they're getting their maximum benefit. This is an opportunity for us then to share our thoughts and communicate them with the patients and other healthcare professionals. And since its inception, Medicare really didn't know where to put this, and so Medicare D plans have been required to provide MTM services to their patients. And if we all followed the evolution of this, in the early days, they didn't really understand what this meant. We as pharmacists who practiced, in environments where we were doing this, say in the nursing home environment, where we're doing chart reviews, or those who were working in the ambulatory care clinics, which were mainly at that time just more in academic settings, we understood the components. But when this got thrown to Medicare D and there was no extra incentive payment, it kind of just sat there in the shadows there for a while. One of the things that's occurring now under the Medicare star ratings is they're looking at, how many times does an MTM occur. However, as we're still in these early days, MTM is not at the forefront a lot of these. And there's been a lot of push of maybe MTM does not belong under the supervision of the Medicare D PBMs, because once again, what did I say earlier? Their job is to just reduce drug costs at whatever means. They're not looking at the whole picture that this drug could also help reduce hospitalization and ER visit costs. We've seen lots of different vendors occur over the years. Mainly the two players that have played out is Marixa and Outcomes. And they have made a big step in helping us understand what documentation is, understanding, the procedures. However, a lot of these MTM programs, how many of them allow you to do follow-up after you see a patient? How many of them actually reimburse you after you see a patient? Some of them do on the outcome side, but many of them, they just want you to talk to the patient one time and boom, you're done. Can you imagine going to your physician, finding out you have diabetes and you only see them one time and they say, okay, you're done? No. So what we've seen with the principle of MTM is these state clinical networks, and hopefully somewhere in the near future, we may see a national pharmacy network. And we'll touch base on these, but those have occurred. Now, if you take a look at this slide shows all the different evolving non-product revenue services that have occurred, from MTM to adherence programs, to diabetes education programs, to immunization, to collaboration with primary care physicians, transition of care, and genetic testing. And we'll explore some of these throughout the talk. One of the other things that I will be doing through all these lectures is on the teaching side, I will either be posting readings or mainly links to readings, probably most of the time links to readings, but I posted under this lecture a link to NCPA has a great site on diverse revenue programs. And when you click on that link, it will go into a lot more detail or give you references of where to check out a lot of these other different programs. Because, as I said before, I stated the goals of what MTM is and what actually is doing. But think about what we do every day in the community pharmacy. We're doing some type of these MTM components every day. because we're helping improve the adherence for our patients and patient safety. Take a look at this sheet here. This is the different codes that are embedded in our DUR system within our pharmacy systems. These are the things that come back as dosage too high. There's a duration issue. There's patient issues. There's drug issues. And what do we do every day with these? Well, we either contact the physician if it needs to be. We either talk to the patient. And a lot of times it's either education or getting the drug change or the drug regimen. Think about this. Every time you do this, does it affect outcome of the patient? And the answer is yes, possibly it does. And that is what we need to start thinking about. How do we change our mindset of we got to get all these prescriptions out to that patient as fast as can, because we've developed our systems that patients just, a lot of patients expect that's what they want. But there's a lot of patients who've relied on us for years, and we've done a great job of taking care of them for these things. And that is why provider status is so important, because that would allow us to be paid for these. People will argue, well, why should somebody pay for provider status when we're already worrying about healthcare costs? Well, think about that slide I showed you earlier. If you had the ability to be reimbursed for these, you could then develop a workflow. You could develop a system that could focus even more on that. And by focusing even more on that, there are studies out there. For every dollar spent in pharmacist time, there's anywhere from $2 to $3 reduction in costs. So, identifying drug therapy problems is right in front of our computer terminals every time we fill a prescription. And every time we're doing that, that is a clinical, monitoring we're doing, and we're helping improve outcome. As I said, one of the things that has evolved over the years is we've seen a standardization of MTM. The biggest key component in MTM is the medication therapy review. That is sitting down and talking to our patient in looking at how are you doing with your drug therapy. What else comes out of that? Well, we make sure they have an updated med list. How many times do patients don't know, why am I taking this drug? What's the purpose of this drug? That's also included. What's the best time to take this drug? We also provide them an education action plan so that they can remember. So we write down what they should be doing. And then at times we're identifying problems with a patient and we're documenting those and sending those to other healthcare professionals to make possible changes or just to be aware of what's going on. So when they see the patient, they can follow up with some of those same entities. Currently, right now, when in January of 2013, this standardization became effect, that when an MTM is done, there has to be a medication action plan and a personal medication list. There has to be, under Medicare sponsors, at the minimum, a comprehensive medication review annually for high-risk patients. And however, if you think about it, probably every Medicare D patient could possibly benefit from at least an annual review. And then they have to do these target reviews. And this is what you see a lot of times in the Marixa system, where you're getting target reviews, focusing a lot of times on the adherence or high-risk elderly medications for a patient that falls under the star ratings. I talked about the standardization. And one of the things that MTM has done is has created the standardization. And so think about this. When a doctor does a physical, how are they trained and how does a doctor start? They always go from head to toe. When a dentist begins his or her exam, how do they start? They always start at the first tooth. One of the things that we've been working at as pharmacy organizations and as pharmacies and pharmacists is what is that standardization? And so there was a joint commission that several years ago developed the standard of the patient care process. And if you look at the patient care process here on the slide, what are we doing? Initially, in that med review, we're collecting that information. We're talking to the patient. We're collecting subjective information and objective information. We may be taking their blood pressure, looking at their sugar readings on their glucometer. And then, after we talk to the patient and we interview that patient, we assess, is there anything going wrong? Is there anything that we could possibly do better? What are their healthcare goals? And out of that, we develop a plan. That could be the medication action plan. That could be a plan that we document a recommendation to the physician, whether it's in writing or calling them on the telephone or seeing them in person. And the next thing is we make sure we see that implementation of that plan. And the last that doesn't happen a lot of times in our current MRICSA outcome system of MTM is we follow up with that patient and we monitor them and we evaluate them and we see them through these changes that hopefully by doing these changes we see an improvement of outcome and reduction in healthcare costs. So here's a case example. We have an 83-year-old female. All right, this is for sake of exercise, say it's September 2nd of last year. And she comes into the pharmacy and and she says, she has a new prescription and she says, also fill everything that I need to be filled. And you say, well, what is that? Well, you have it in your system. Just fill it. Ever hear that by any of your patients? And here's what you got. You got spironolactone 25 milligrams once a day. And then here's the rest of her profile, and here's the last fills. Now take a second and just look at that slide. Think to yourself, when I look at that, are there any issues happening? Do I cap what's going on here? The old community pharmacy snapshot. Look at this. I don't have any labs yet. I don't have a medication list. But I know a couple things. One, spironolactone, potassium-sparing diuretic. She has a K-Dor prescription, but we haven't filled that in 2 months. I wonder if the doctor wanted her to discontinue that. I better check with the doctor. In 2 more lectures, I'm going to hear about high-risk medications. I know Lanoxin, for a patient that age, that's a pretty high dose. I wonder how she's doing and making sure she's not having any side effects. And maybe that dose needs to be reduced. Maybe when I bill the insurance this time, it's not covered under Med D because the dose is too high, and so I am calling the doctor regardless. She's also on lisinopril, which also can affect her potassium, so I really want to make sure she's following up the doctor and getting any labs. Verapamil, it's a good calcium channel blocker, but hey, you know what? It can suppress the AV node of the heart and we know that sometimes that can worsen heart failure. I wonder if she was on that before she started having heart failure, which it sort of looks like that's what she has. I don't know exactly yet, but looking at her drug therapy, I'm thinking that might be because she's also on the Lasix. She's got Alzheimer's disease. She's on Aricept, or at least some type of memory problem. I wonder how she manages her meds. Could she use a pill box? Looks like she's doing pretty good on her refill rememberings, but it might still be early on in her disease, and you can never, be too soon to plan this. And then she's also on hydroxyzine, which I also have learned that is another Beer's high-risk drug, and, well, that can affect memory and cause confusion. And I wonder if she's still having this itching or, and does she use anything OTC, making sure she's not using products like Benadryl. So I need to talk to her about that. Now look at that. Everybody in the room, I know you knew that. All right? I'm not there to quiz you right now, but I know you knew that because we look at these every day. And this is what we do as the drug expert for that. Another great tool to help you with that is think about these 10 questions. Is there an indication for the drug? Is the medication effective? Is the dosage correct? The directions correct? The directions practical? Are there clinically significant drug-drug interactions? Drug-disease interaction? Is there unnecessarily duplication with other drugs? Is the duration of therapy acceptable? Is this drug the least expensive alternative compared to others of equal utility? Ask yourself these questions when you're doing an MTM or preparing to do an MTM. And if this becomes ingrained in your thought process, you're already there being able to do clinical services. And if you're not feeling comfortable, maybe you're not the right person to do this. Well, who on your staff can do this? What pharmacist? Maybe that's a great interview of a future clinical pharmacist. Give them that case I gave you and see if they can identify any problems without asking them any questions right away. This is how we need to start thinking as we incorporate ourselves into these services. The other thing we need to start thinking about as we incorporate ourselves into advanced services is our documentation system. We've done a great job over the years of developing a documentation system for filling prescriptions. All right. We know how to fill, we know how to document if it's refilled too soon. We know how to document if we talk to the doctor about a high risk drug interaction. But we need to start documenting when we're doing these advanced services, and so we can start measuring success. And what type of successes should be measured? There should be economic, clinical, and humanistic. How can you track these? One of the things that these pharmacy care networks are hoping to do, and the MTM, Morexas, and Outcomes is they are creating documentation systems for you. There are several companies out there. A lot of our pharmacy systems may be able to do documentation. How will you measure these? How do you measure those? Just think about every day. What do you do at the end of the day? You print your report of, what were your daily sales? What was your gross margin? And what have you and how did you trend this month compared to last year or last year's month? What do you do when you see those numbers? You either say, hey, we're doing pretty good. Maybe we're not doing pretty good. You evaluate. Hey, maybe we need to take a look at our inventory. Tracking clinical incomes is no different, especially if you're starting a new service where initially the return on investment from being paid for the service may not be directly. Maybe some of these services are indirectly by looking at our increase in drug refills and new customers. All right. So you need to look at such as, what is my return on investment? If I'm working with other healthcare systems, what is the return on investment by reduction of healthcare costs? If I'm working with a patient, what is the patient benefiting out of this? Maybe you're helping them be healthier, maybe which is a quality of life. And so there might be humanistic things we measure. And then obviously there's clinical measures. If we're treating somebody with diabetes, where did their hemoglobin A1C go? What are disease-specific measures? So just to refresh what we said, outcome measures, we need to look at things such as return on investment. So if I start a diabetes program and I'm going to become accredited so I can bill Medicare, and I'm going to have my pharmacist do this so many hours per week, what am I bringing in revenue? Track my diabetes sales, track my refills, track new patients. What are the economic measures that I can measure for the success of this program? Clinical outcomes. A lot of the different clinical services we do, whether we're partnering with other healthcare entities or services, we actually have to improve. So maybe we evaluate we're already doing that with the star ratings, evaluating our adherence rates. And then if we're doing disease-specific type of programs, looking at those quality markers such as hemoglobin A1C and diabetes, lipid profile and hyperlipidemia, blood pressure readings, and so on. And then we also should do patient satisfaction surveys. Anybody who's ever gone to a hospital setting knows you're always getting surveys, and you want to be able to look at how do the patients see you. Maybe doing a survey among your healthcare entities in the area of how do they perceive you. Maybe when you're first trying to find out and want to dabble in these new type of services. The other thing that we know in these services that why do we do them? Why do we want to do them? Well, one, we want to diversify ourselves possibly. But the other thing is we know that if we own the drug therapy knowledge, and for example, under Medicare D, that making people more adherent may lower Medicare Part A costs. And just here's a couple examples. An Advair inhaler, and this price, can vary, and I don't have the AWP completely up to date on this, but a cost of an ad for an inhaler, which we know is an inhaled corticosteroid and long-acting beta-2 agonist, costs anywhere around $4,000 a year. One hospitalization of an asthma patient can be close to $12,000. Think about how our adherence program, how our education contributes to the decrease in preventing that hospitalization. Identifying a high-risk drug in the elderly that may cause a fall or confusion. Think about what it costs if somebody has to be hospitalized. Think what happens if they have a hip fracture. And then also think about their quality of life. Every time we do some type of intervention of that, that has a big cost savings impact. So we've talked about the value-based healthcare. We've talked about the review of MTM principles and how they're the cornerstone. Let's talk about these enhanced pharmacy service networks. We are starting to see grow across the country these enhanced pharmacy networks. And what the purpose of these enhanced pharmacy networks are that it's providing a standardization. It's putting together, just like we create a network of signing a contract with a PBM, or if you're part of a PSO, all right, the more people enrolled in it, the more ability we're able to negotiate with other healthcare professionals. We are seeing a trend in, National Governors Associations met several years ago wanting pharmacists to be more integrated into our healthcare system. So we do have champions. There was the Surgeon General report from several years ago. There are people, despite in our every day of seeing how our reimbursements are cut by the PBMs, but there are people out there looking for this. The biggest, most successful of these state MTM programs evolved out of North Carolina. North Carolina has been doing this for several years, and they created this community pharmacy enhanced service network. And I refer that you check out the website to give its more. But what the key conception of this was finding pharmacists, and 80% of the pharmacists in this network in North Carolina are independent pharmacists. And they're working every day with physician offices, hospitals, home health care institutions. And this has become such a successful program, is showing those reduction in costs I talked about earlier, that NCPA has recently, with North Carolina, begun to develop a national enhanced service network. And what has these networks been able to do? For example, in Wisconsin, they have had a quality collaborative state network where pharmacists were taking care of Medicaid patients and being reimbursed for this. Minnesota, which is probably one of the longest acting ones, had been reimbursed for this. And these reimbursements, I can give you an example in the Minnesota one, the reimbursement is developed that it covers pharmacist time, but it also provides a profit incentive for that company to want to be part of this. And so that's a key one too, as these enhanced service networks, the goal of these are to create a network to contract with a healthcare plan looking for pharmacies or pharmacists that want to offer MTM type clinical services, and in turn we would be paid for those at a good rate so that we could do this and it becomes part of our workflow, or possibly a separate company. Pennsylvania has also begun this. It's been a slow start, but why is this done? Because even if we get provider status tomorrow, and I know the House bill and the Senate bill have changed on these numbers, so bear with me here, but the initial bill is just a start. It's only for medically underserved patients. And if you take a look at Pennsylvania, yes, we do have medically underserved areas where we would have provider status, but not all our pharmacies are located in those medically underserved areas. But we know that in those places where it's white and they're not underserved, all right, that there are needs for pharmacy to be part of this. And so Pennsylvania, through PPA, has developed the Pennsylvania Pharmacy Care Network. And what this Pharmacy Care Network has developed, they developed the education resources. Many of you may have gone through this. I believe Value is looking to offer this program sometime this summer, possibly around the showtime. and there will be more detail of that to come later. But what is the purpose of this care network is that it can work with payers for those who are part of this network, that the pharmacies and the pharmacists that are in this network can be able to provide MTM services and be reimbursed. And so there's a pilot possible project that's going to be coming up here. I can't speak because they haven't signed the contract, but there is a payer in the near future that's going to be the very first payer for this Pennsylvania Pharmacy Care Network. And this is just a listing of a lot of different pharmacies that have already offered their logo and are signed up for the network. So if you'd like to find out more information about that, please go to the Pennsylvania Pharmacy Association, and I actually will, under our collaborative agreement section, I'll put a link to that on our teaching site. Now let's take a look at how can we improve patient outcomes through the various different types of services. Okay, so a lot of you probably already do immunizations, and we probably every year you plan what your flu shots are going to be. Can you remember the time when maybe you first started immunizations, you had set appointments, and maybe you still do set appointments? But what did a lot of us done? We've developed workflows to be able to put those programs, all right, that somebody walks in, hey, you want a flu shot? Sure, we can give you a flu shot, all right? A lot of us have adopted adherence programs, sync programs, to address the needs of our patients. We have the future networks, the MTM networks. And some of us have been beginning to dabble in transitions of care, diabetes education programs, and collaboration with primary care physicians. But how do these services improve patient outcomes? Think about our immunization. Think about how many people you may have prevented not having to suffer a hospitalization from the flu this year. And if you read the statistics, the flu shot pretty much was close to dead on, even though, some people have, and we still are seeing flu cases reported today. But one thing especially in geriatric care, how pneumonia shots, Tdap shots, help prevent that. Have you dabbled into Tdap pneumonia, Hep A, Hep B, travel vaccines? All right? These are great preventive services that help prevent future hospitalizations and ER visits, but they're also a good reimbursement model. And it's a great start to, even though we're still selling a product, what are we also selling? Our administration services. I got a tip when I was at NCPA last time, and I thought it was a great tip. A gentleman does at his pharmacy that when they do their flu clinics or offer flu shots in the fall, they actually have a questionnaire that goes along with it, asking them what other vaccinations have they've gotten, and if they have not, and if they are of that criteria for that vaccination, they have a check mark. Can we follow up with you of possibly talking to you about those vaccinations? And he's seen his vaccination program grow immensely over this. A lot has gone into adherence programs, using the Equip platform to evaluate who's not adherent. Some of us use different software vendors to help evaluate this, or our software systems are doing medication synchronization. And this is a win-win. The more adherent patient is, the more likely they're going to be better. And also, the more likely they're going to be better, the better their health outcomes. How many of you have shared your adherence program with your local physicians that you do this? How many of you marketed that? The other thing is, one of the things that also is coming out of the Pennsylvania Care Network is what's called a pharmacy locator app. And so that locator app is a way for, say that a home healthcare agency is looking at somebody that does adherence packaging or synchronization. You can find that on that app. And we know that adherence does. MTMs, if we can do the follow-up with MTM, and that is what these, like the North Carolina project has shown, and I'll show a couple of those in the collaborative practice talk, they have been shown to reduce costs. All right? Explore partnering with hospitals, physician practices, home health services. establish yourself as a pharmacy that is part of that healthcare system. And so when you go back, think about what service can I implement? What service have we tried but we really didn't put our full effort into that we may be able to grow this even more? How many of you gone out and taken the time to take a local physician out to lunch or dinner to talk about your services or present to your senior center or talk to maybe people on the board at the hospital? Think about those as you are. And so, like I said, adherence programs are not just synchronizing and getting all the pills filled on the same day. It's about talking to the patient, identifying why they're not taking certain medications, helping them with the reminder systems, whether it's multi-dose packaging or some type of pill box system. Check out, there's different technologies out there for you to be able to do that. We're going to talk about collaborative practices, but through collaborative practices, and we've been working with our local physician who's actually in this picture, Dr. Miller. And one thing that I've found is go out and find the physicians who are still independent, that are not part of healthcare systems. Not saying that you can't work with a healthcare system, but one thing that I found that those who are still out there trying to stay independent, they're a lot like us. We have a lot in common. We're always fighting off reimbursements. We're trying to be able to do multiple things because we're busy and sharing those services. And we've been working with Dr. Miller for over the last close to 7 years now. And we've now finally begun the development of collaborative practices that have been award winning and hopefully more in the near future. Transition of care is a big one. And there was a recent study that was published last year, and it showed that a transition care program run by pharmacists can save $2 for every dollar spent. And so these transition care programs can be anything from calling patients post-discharge and then sharing that information with the physicians and their healthcare professionals, or some have actually developed programs which are delivering the meds right to the hospital to the patient upon discharge. And some have seen win-wins with those, all right? Because nearly 1 in 5 Medicare patients discharged from hospital are readmitted within 30 days. And this is a big deal for hospitals, all right? They're not. The University of Cincinnati, in partnership with Kroger Pharmacies, showed that in their transition of care program, they saw a 20% reduction in readmissions for patients receiving counseling and medication management by a pharmacist. And once again, it's doing our skills that we know how to do. It ties out of MTM. It's sitting down, talking about their medications. When somebody gets discharged, how many times they get confused? Should I still stay on this med? What's this new med for? Why am I taking this new med? I don't really see any good effect with this new med. When's it going to take effect? Well, they may not see effect of it for maybe 2 to 3 months. They may not understand the purpose of taking a statin post an MI. All right, and how it may prevent future MIs. Making sure we're sitting down, but this is a great opportunity. And in the near future, I'll talk about it in the next talk, there possibly may be revenue streams through collaborative practice to be paid for these services. Another option, NCPA has offered this training program for the last close to 7 years, is pharmacies can get accredited to provide diabetes education. Obviously, we know there's lots of diabetic patients. There's a decline in our country of endocrinologists and CDEs. I was just driving the other day and I heard on KDK radio in Pittsburgh an advertisement for endocrinologists for Allegheny Health Network. I've never heard an advertisement for a physician, but they were actually advertising right on the radio. Hospital programs that used to offer diabetes education programs are not always, are going by the wayside. And a lot of times they don't offer convenient times. Their programs are like from 7 to 2, where a lot of our early type 2 diabetics, they're still working during the day. All right. What is a diabetes education program? It's a comprehensive collaborative process of working with people with diabetes, educating their disease, and the ultimate goal is to reduce healthcare costs, and improve quality of life. What you teach in this diabetes education program is healthy eating, being active, how to take their medications, problem solving, reducing risk, and health coping. And what's the requirements for this? Well, if you just get certified to do Medicare, obviously they need a referral physician order to do this. And if the patient has never had a diabetes education program, they can qualify up to 10 hours of the education program. And for those who've already had an education program, they can actually be billed 2 additional hours. And so once again, you got to get a diagnosis code. This is billed under Medicare B, so you have to be certified, accredited under Medicare B, and then you have to fill out additional forms for that. But like I said, I encourage you, places that you can find. I'm going to drop back one more slide here. The American Association of Diabetes Educators and NCPA have great resources of how this can happen. There's a couple pharmacy companies out there that can do that. If you go to those diverse service website of NCPA, you can find those links. And like I said, there's opportunities that out of this program can also start other things, such as you may see a growth in your prescription business, diabetic shoes. Maybe you have other programs such as smoking cessation. And so the diabetes education program, think about it, the diabetic is one of your cornerstone type of patients that can lead to other streams of revenue. And obviously the one thing that this program, like all clinical service programs, have shown that it can help decrease hospitalizations and ER visits. It may increase prescription drug costs because you're making them more adherent. It may increase doctor visits and monitoring, but those costs far are outweighed by the reduction costs in hospitalizations and ER visits. Another area that is emerging is point of care testing. A lot of physicians, especially primary care physicians, are overwhelmed, and to seeing patients, for just a level 1 type of visit, which could be, do I have strep throat or don't? A lot of times they're just, they are not interested in it, or not that they don't care, it's just very hard. And so these point of care testings, we've seen pharmacies grow for this, especially in other states. In Pennsylvania, there is opportunities. NACDS actually has a point of care testing certification program. I do believe both Duquesne and Pitt from time to time offer that. I'm not sure if any others in the state do. But what does it do? Well, if you become certified in point of care testing, these point of care testings do require you get a CLIA waiver, which is basically getting, a lab license at a very low level. Some of you may have done this in the past for cholesterol and glucose testing, but where does this happen? Well, this is a service that maybe be able to be billed through the physician through a collaborative practice agreement. And the other thing, through the collaborative practice agreement, you may help develop, an initiation of, once you do the strep testing, you call the physician. If it's positive, then the physician gives you an antibiotic order. And it's another way to capture a patient. You see this actually, especially not here in Pennsylvania right now, but you see in your chains such as Walgreens, especially, them using this program at the point of care. Another area is pharmacogenomics, genetic testing. Obviously, this is a big growing area where pharmacists can possibly get involved in looking at, getting, not, performing the swab, and there's different programs out there of how you get paid, but a possible opportunity to get paid through collaborative practice with a physician is sitting down and reviewing the results and making changes therapy for the patient along with a physician. I encourage you to talk to the folks at Value. There's several different programs. I know we're exploring a couple of them, and it's a vast growing area. When it first started, the problem happened that a lot of Medicare was paying for it, and now it's not. And so, but it's an area that I think is still going to come back around. It's not going away. And so I encourage, this is kind of like the next immunization. I think that all of us need to be involved in the future. And finally, as we finish this talk, what are some important steps to getting started? Well, remember, success is doing the common things uncommonly well. The best way to start incorporating these services is first looking at how is our workflow doing of our other services of filling prescriptions. What services can we offer? Remember, there's two things patients and customers want. They want to feel good and they want their problem solved when they use your service or business. And so what can we do? What type of service can we offer that will do that? Some of you may feel, well, I feel restricted because of, lots of different progressions. Will my patients accept this? Will I offend the physicians? What's my liability? So far, because these are within the scope of practice of pharmacy, we have not seen a change in liability, but you need to check with that. What's my legal ability in the scope of practice? And so I'm going to talk about collaborative practice and refer more to physician for Pennsylvania, but depending upon what state you're in, look at those. Do I need to go through any other certification programs? What lies me there? Because you have that clinical ability. We all have the great education about our drug therapy. We may need to sharpen the saw and go through other training programs, but the one thing that we have is we have experience with patients. We know how to talk to patients. We know how to talk with our healthcare providers. And so don't let those things that I talked about just on that last slide be the deterrents of, I just can't do this. The other thing, as I said, you need to think about your community pharmacy workflow and how can we shore this up so we may be able to slowly allow our pharmacists to have more time to do clinical. But then you need to think about, what is your clinical community workflow? How do I involve technicians? Some of these reimbursements may be not cost effective enough that using a pharmacist to do all this, we actually lose money. And so what roles can my technician do to help implement these services, and what roles do my pharmacists do? And then also, as I talked about earlier, how do we document the success of these programs? So if holding you back is the lack of knowledge, unable to develop a profit structure, that's slowly happening. Not able to free my pharmacist from the dispensing role. Sit back, think about the workflow, think about technology. My patient does not want cognitive services from pharmacy. Sometimes the greatest services, the greatest things are things we never knew. For everybody in the room right now or wherever you're at, pull out your cell phone. Can you get the email on it? Can you look up the internet on it? Can you play some type of game on it? Do you ever think you would be carrying around a computer in your pocket? All right. And that was just what? All right. 10 years ago. And so think about that. Sometimes your patients don't realize they need that. So the future is now, whether it's diabetes education programs, whether the cornerstone is probably owning adherence. Our MTM programs are also the cornerstone, and immunization. I thank you very much for this first lecture, and I look forward to hearing the other lectures. During the live lecture, Greg Drew will be reviewing the assessment questions and going through with those for you. Okay? Thank you very much.